after all these beautiful studies in pharma, we have to look into the studies related to LAA occlusion. And if we do a search on PubMed, which I did 2 days ago, we see 269 publications, but only one randomized clinical trial. And most of these publications are are small single-center observational studies. Nevertheless, LAA occlusion was included in the guidelines of 2012 as a 2B indication for patients with contraindication to oral anticoagulation therapy. On the other hand, FDA approval for Watchman device is expected based on a non-inferiority and later superiority versus warfarin in patients that are eligible for this treatment. So, PROTECT-AF study, we cannot escape that because this is the first randomized study and the only one which is published. It was a non-inferiority design. I will go through this study quite fast because I'm sure most of you are familiar with it. 2-to-1 device versus control, 800 patients. Here we see the design of the study where you can see that all patients, even after LAA occlusion, they received warfarin for 45 days. Then we have an evaluation with TE, and then we decide whether we stop or not warfarin. And on the other arm, of course, patients are treated with warfarin. 87% of the implanted subjects were able to stop warfarin in 45 days. And then sorry, go back. In 45 days, you have 87%. Then at 6 months, 92%. At 24 months, 94% of patients stopped warfarin. The reasons for remaining on warfarin therapy after 45 days was observation of flow in the left atrial appendage, and this is something that we will discuss today related to complete closure and leakage, etc., physician order or other. The primary endpoint was cardiovascular death, stroke, or systemic embolization, and here we saw that LAA occlusion with the Watchman device was not inferior to warfarin. And as you can see in this slide, in all-cause stroke, again, it was non-inferior. And in hemorrhagic stroke, as we could expect, LAA occlusion showed superiority. The main concern of this study was adverse events. Most of it was pericardial effusion and that required drainage. We had some air emboli and also major bleeding. And major bleeding was quite high because these patients were treated with warfarin even after LAA occlusion. So pericardial effusion was the most common safety event. And throughout this study, there were some procedural modifications and training enhancements that resulted in an improvement, as you can see here, in adverse events if you compare early patients versus late patients. The conclusions of this study was that LAA Watchman technology offers a safe and effective alternative to warfarin in patients with non-valvular AF at risk for stroke who are eligible for warfarin therapy. And there was a substantial learning curve effect. And there was a second randomized trial that was ongoing. This is the PREVAIL study that is designed to confirm the results of PROTECT-AF. It has not been published, so we only have 1 or 2 presentations on preliminary results. This study shows an improved safety profile for the Watchman device, and 2 out of 3 primary endpoints were met. But what was maybe the most striking and the most interesting finding was the long-term results of PROTECT-AF. And here you can see that the device, after some time, becomes better than control in the primary efficacy endpoint. And this was really a very hard endpoint because you see also in this slide, we have improvement in all-cause mortality. You see here that these 2 curves are separating, and this comes with time, which is normal because the effect of the treatment You get the adverse events first, and then you have the left atrial appendage occluded, whereas the medication, it's for life. Now, the PROTECT-AF had these 4-year results showed that we had, in the primary efficacy endpoint, an overall event rate of 2.3% for Watchman, and then 3.8% for control group. So that showed superiority, as we mentioned. In the intention to treat analysis, LAA Occlusion showed a relative risk reduction of 34% for all-cause mortality, 40% for stroke and embolic event or cardiovascular death, and 60% for cardiovascular mortality. Of course, this study, as any study that we try to do now on LAA occlusion, has the limitation of the size. Here, also there was a higher studied dropout rate in the control group. And the warfarin group had a greater all-cause death than previously reported in the literature. So there was also a relatively low CHA2DS2-VASc score in this study cohort that was average 2.2. And PROTECT-AF, of course, did not include new oral anticoagulants, which is another interesting topic to discuss later. So study population that also does not match, of course, the European daily clinical practice on intolerant patients. And now we move to a collaborative effort that was done to show some evidence regarding the Amplatzer Cardiac Plug. So this is a multicenter study that is finished now. And we investigated the safety and feasibility and efficacy of LAA occlusion with the Amplatzer Cardiac Plug. The data were prospectively collected and retrospectively analyzed in a non-randomized multicenter study. And this study shows the real-life experience with this device. So 969 patients were finally included in the study. 27 patients were not implanted, and 14 patients were lost to follow-up. So at the end, we had 928 patients in these preliminary results that we reported in TCT. And we used these patients to evaluate the stroke reduction and bleeding reduction. Here you can see the enrollment per center. We have very, very experienced centers with more than 100 implants, and also non-experienced centers with less than 10 implants in the study. The enrollment per year is shown here. And these are the baseline demographics of this cohort. I would like you to concentrate here. 55% of patients were more than 75 years old, and 36% of patients had a prior stroke or a TIA. And this is higher than all previous studies on LAA occlusion. Half of the patients had paroxysmal AF, and the other half permanent AF. The mean CHA2DS2-VASc score was 4.4, and the mean Hess-Bled score was 3.2. Again, higher risk patients than compared to previous publications. And this is a very interesting slide, I believe, because it shows what was the indication in this real-life cohort. What was the indication for left atrial appendage occlusion? And the question is, was this indication in accordance with the guidelines? So we see previous major bleeding was the indication in 41% of patients. Some have double indication, so this is not much. This is not equal to 100. So a higher bleeding risk. But we had in 1/4 of the patients, the procedure was done to avoid triple therapy. Also, we had 16% of patients that were treated because they had a stroke on warfarin. And previous minor bleeding, 11%. In total, about 3/4 of patients were treated according to the recommendation of the ESC guidelines. Now, the success rate was pretty high. 97.2% of the untaped patients were successfully implanted. Here you see the average device size that we used. 10% of cases were done through a PFO, although it's not officially recommended. And in 1/5 of the procedure, of patients, we had a combined procedure. Usually it was coronary angiography, sometimes PFO closure, or even PCI, TAVI. And this is real life. This is not a randomized study, of course. Now, with respect to major adverse events, we chose to adopt the definition that was used for PREVAIL study in order to allow comparisons. So it's an acute 7-day occurrence of death, ischemic stroke, systemic embolism, and procedure or device-related complications requiring major cardiovascular or endovascular intervention. So in this cohort, we had 6 deaths, or 0.6%. And here you can see the description. We recorded all deaths. Not all of them were directly device-related. For instance, we had 1 death because of pneumonia of the patient during hospitalization. And these were pretty sick patients, old patients, high risk. On the other hand, we had 1.2% frequency of pericardial tamponade, a major bleeding 1.2%, a stroke 0.7%, and in total, we had a 4.30% rate of major adverse events, which is comparable to previous reports. This is probably another interesting slide when you can appreciate the changes in anti-thrombotic medication in this cohort between baseline and last follow-up. And you can see here that aspirin monotherapy increased from 37.5% to 63.3%, almost doubled. On the other hand, the use of warfarin went down from 17 to 2%. Triple therapy, aspirin plus warfarin went down, and triple therapy almost went to 0. The closure rate in TE follow-up, which was available in 536 patients, the closure rate was very high. We chose to use a more strict criterion of the 3 millimeter color jet on TE for a definition of complete closure. And using that, the complete closure was 97.6%. This is the survival curve. This is the Kaplan-Meier curve. Here we include also the 6 deaths that are very procedural. In total, we had 62 deaths at follow-up. 20 of those was of cardiovascular origin, 42 was non-cardiovascular, but none was reported to be related to the device. That was, in this slide, we can see the changes, the effectiveness of left atrial appendage occlusion in stroke reduction versus the estimated predicted stroke rate, annual stroke rate by the risk scores that we discussed previously. And you see that we expected in this cohort, in these 928 patients that were implanted and follow-up, with complete follow-up, we expected a 5.62% annual stroke risk, and the observed risk was 2.06%. And this includes strokes in TIA, and this includes also the strokes that were in the peri-procedural phase. So approximately 1/3 to half of these events were related to the procedure. Now, on the right side of the screen, you can see the effectiveness in bleeding reduction. This would be the annual bleeding rate if the patient were receiving warfarin. And this is the observed bleeding rate. We go from 5.5% to 2.2%. And again, here we include all the major bleedings that were reported in the peri-procedural period. So the summary of this study is that in this 969 patient cohort, LAA occlusion with the Amplatzer Cardiac Plug had an excellent implant success rate of 97.2%, a 4.30% rate of peri-procedural major adverse events. That was in line with previous reports. And during these 1,200 patient years of follow-up, LAA occlusion with ACP achieved a 98% occlusion rate at follow-up TE, a 63% reduction in stroke, and a 60% reduction in major bleeding as compared to the risk scores predicted rate. And this 60% reduction is in line with what the amount of reduction that we get from oral anticoagulation. Now, just one slide to show you our plans for this ACP study group, as we chose to call it. The enrollment for this registry stopped when we collected 1,000 patients implants in November 2013. We submitted a manuscript 3 days ago for peer review. And the final results of this registry will be presented in EuroPCR in Paris in May 2014. There are some ongoing projects, and I would like to thank all the participants in this registry. This is a 22-center collaborative, physician-driven effort, and now we have some ongoing projects to evaluate leaks and device thrombosis and see what's the meaning of this. We have planned to have an independent TE adjudication to increase the credibility and the quality of the reported data. Also, we will investigate left atrial appendage occlusion in special patient populations, like patients with real-line impairment, as we discussed previously. This is an ongoing study, has already started. We will look into cost effectiveness of this therapy, and we will also evaluate the risk-benefit based on the indication and also based on the baseline characteristics of these patients. Now, this is, I think, almost my last slide, and I'd just like to discuss some unsolved issues on this field. Now, I think that the best and maybe the most important for the moment unsolved issue is the lack of standardized definitions and the lack of a common language when we talk about left atrial appendage occlusion and related studies. We have to agree on how we will, which definitions we're going to use for indications, for adverse events, and even for endpoints. And just to give you an example, for adverse events, so what is a stroke? We have to define what is a stroke. This so simple thing has to be defined in the studies, and we have to define whether a major bleeding is different than a pericardial tamponade, or is there an overlap there, or even for the endpoints, we have to discuss what we're going to look into to be consistent and maybe to compare our results with other studies. Now, of course, there is a need for a randomized clinical trial. We have to confirm the results of PROTECT-AF on whether the left atrial appendage occlusion is effective for stroke prevention. The question is, should we target low or high-risk patients? A lower-risk patient will benefit from the therapy. Typically, he's younger. He will benefit because he will have less years of life without, a lot of years of life without anticoagulation. On the other hand, in high-risk patients, we can have events fast, and we can maybe prove and have smaller studies. Another question is, should we do a study on patients with or without contraindication?
Move this slide to the panel discussion because it's very important. It's very great, and
I will just read the results. Okay, the conclusions. Okay. So that's the previous version of my presentation. Okay, never mind. We'll conclude now, and as a take-home message, I would like to say that left atrial appendage occlusion with a Watchman device showed superiority versus warfarin in patients that were eligible for oral anticoagulation. In this all-comers LAAO study with the ACP, we showed a stroke reduction that is comparable with oral anticoagulation therapy studies. There is a need to standardize definition to facilitate future studies, and also there is a need for more evidence and randomized clinical trials in order to conclude on LAAO indications. Thank you very much.